And we welcome the chairperson, 1 minute, 11 o'clock, hai na? Yeah, Dr. Tariq Qureshi sir. Can we have the moderator slides on, please? Moderator slides on, please. AV team. Yeah, I'll be the moderator for the session. Next slide. Yeah, we welcome our chairperson, Dr. Tariq Qureshi, sir. He is the Principal Government Medical College, Anantnag, a brilliant vitreoretinal surgeon and laser specialist. Welcome, sir. Yeah, next slide. Yeah, Dr. Manvi D. Sindal, ma'am. She's the co-chairperson. Is she present here? Okay, she is the head of Retina Services, Arvind Eye Hospital, Pondicherry. Probably she'll just join us. Next slide. We have the judges for the session here. Dr. Sumita Mohapatra. Is she present here? Next slide. Professor Dr. Sanjay Kumar Daulat Thakur, sir. Yeah, we welcome you, sir. He's the head of Department of Ophthalmology at the College of Medicine and Sagor Datta Hospital. We welcome you, sir. Next slide. Professor Dr. Amit Raj, sir. Is he present? Yeah. We welcome you, sir. He is the professor and head of Department of Ophthalmology at AIOS Patna since 2018. Welcome, sir. Next slide. So the rules are the time of presentation is 4 minutes. There will be a beep at 3 minutes and the screen will be blank at 4 minutes and discussion is 2 minutes. So the total of 100 marks that will be for evaluation on the content, originality, use of statistical analysis and the scope or likelihood of publication. I hope all the judges have the evaluation sheets. Evaluation. You have the evaluation sheets, right? Okay. So can we start now with the first speaker? Yeah, Dr. Jaydev Nanda. Yeah. The next speaker, please be ready with your presentation. Dr. Prashant Singla. Timer is for 4 minutes, no?
Good morning, everyone. Good morning, everyone.
Yeah, you can start. AV team, please keep the timer properly at 4 minutes. Yeah, please start.
Good morning, everyone. I am going to present my thesis on comparison of ganglion cell layer thickness on optical coherence tomography and waveforms on pattern electron-retinography among glaucoma suspect and healthy controls. So, as you all know, glaucoma is characterized by chronic progressive optic neuropathy resulting in characteristic visual field loss, and the prevalence is being 3.54% worldwide and 2.3 to 4.7% in India. By 2040, it will be around 111.8 per million cases. And all know standard optometric perimetry is being the gold standard for glaucoma detection, but it requires at least 25% of RGC loss to be detected. So for the pre-perimetric glaucoma cases can be assessed structurally by OCT and functionally by pattern ERG. So rationality behind our study, as these OCT and PRG are the non-invasive and objective method, and it will help in early assessment of developing glaucoma. So to novelty is to our best knowledge, no such study has been taken on the ganglion cell layer thickness alone and compared it at different locations like 3 millimeter, 3.45 millimeter and 6 millimeter in macular region, and very few studies as compared by PRG parameters among glaucoma suspect and healthy controls. So we expected that there will be decrease in GCL thickness and increase in implicit time and decrease in amplitude of pattern ERG waves, and which can be utilized to prevent the progression of the disease earlier. So our aim was to evaluate the difference in the above said parameters between the two groups, and the objective was to measure the thickness of GCL and OCT on OCT and implicit time on amplitude of P50 and N95 waves on pattern ERG. So our study design was cross-sectional observational study on in AIOS Patna, And we included subjects of 40 to 60 years of age with suspicious optic disc comprising of more than vertical optic ratio more than equal to 0.5, or there may be diffuse or focal narrowing, disc hemorrhage, or asymmetric appearance of optic disc of more than 0.2 between the fellow eye. And subject with the normal finding, we have taken as control group and excluded the known cases of glaucoma, any cases of angle closure, IOP more than 21 millimeter mercury, more than 4 diopter, and having any visual field defect and coexisting any retinal disease and medial opacity. And with the following assumption, we have calculated the sample size to be around 25 in each group, but we have taken more number of patients, 50 in each group. And after comprehensive evaluation with high IOP and angle closure cases, we have excluded all those cases who have the visual field defect, and then further proceeded for proceeding. And these are the pictures of our own patients, and these are the pattern ERG waveform of our patient. Coming to the statistical analysis, we have analyzed the data on Jamobi software, and p-value of less than 0.05 was taken into consideration. And we found that there was significant difference between the control and suspicious disc group at 3.45 millimeter and 6 millimeter. And for the P50 wave, there was significant difference in P50 amplitude and implicit time. But for the N95 wave, we didn't find any significant difference for the amplitude, but significant difference was noted for the implicit time. So for the OCT on discussion, our finding was similar to Zhou et al. And Zhong et al., but they have taken the GC-IPL thickness into consideration. And for the P50 wave, we have similar finding in comparing to Jion et al. But the Zhong et al. Have decrease in amplitude of P50. Benkel et al. Have no significant change. And for the N95 wave, we have found the similar finding to the Zhong et al. But Zhong et al., Benkel et al. And Jion et al. Have found significant decrease in N95 amplitude, but we did not find any significant change. So our limitation was small sample size, hospital-based cross-sectional, and corneal electrode. Conclusion: the basis of morphology optic disc, structural functional assessment can be done, and thickness analysis of GCL alone can also help, and pattern ERG findings can be detected on the glaucoma suspect patients.
Thank you. Judges?
Was the control was selected from the OPD or from glaucoma clinic?
Yes, the controls are all selected from the OPD. They are, as the patients are registering, we are consecutively selecting the patients.
Okay. And what were the whether MRW and RNFL was also studied, or?
So it was taken on the OCD machine, but we have not taken those parameters into our consideration.
I think you mentioned in your slides in the beginning that no study has been done, but then in the discussion you mentioned couple of studies. So what's the difference between your study and the other studies?
Previous studies have taken GC-IPL thickness and GCC into consideration, but we have taken only the ganglion cell layer thickness, and also at different locations like 3 millimeter, 3.45 millimeter, and 6 millimeter.
Which machine are you using?
Heidelberg HRS spectralis, OCD spectralis.
Okay. So why didn't you take the glaucoma patients for comparison? You could have taken them also.
Yes, the previous studies have shown that we are comparing glaucoma suspects and controls. Previous studies have been there comparing glaucoma suspects and early glaucoma and late established glaucoma cases. So we want to know whether there are changes is present also in glaucoma suspects or not in comparing to controls, so that we can assess them earlier and we can prevent the disease before.
No, how do you know these are glaucoma suspects? They may as well be glaucoma patients, because by your criteria, if you do visual fields and if that is positive, they may be glaucoma patients.
No, sir. Though on visual field analysis, the patients, the subjects who do not have any perimetric changes, we have taken them into. Yes. Yes, sir.
Thank you so much. I would like to now invite the second speaker, Dr. Prashant Singla. Is Dr. Tanmay Mohapatra here? Yeah, please load your presentation immediately and be ready immediately.
Good morning, everyone. So in my thesis, I have studied the evaluation of meibomian glands, the structural and the functional component in the patients of VKC using the non-contact meibography. So, a little bit of background. An association between the severe ocular allergies like vernal keratoconjunctivitis and atopic keratoconjunctivitis is known between the ocular allergies and dry eyes. Many reports have been published. The proposed pathophysiology that is there in the literature is that there is conjunctival inflammation and there is post-inflammatory surrounding tissue remodeling, and there is that affects the adjacent tissues like the meibomian glands, and this is altering the structural and the functional aspects of the meibomian glands. But the literature regarding the effect of VKC on meibomian glands is scant, and the published literature is on confocal, which has its own drawbacks, per se, that it has a limited field of view and it does not assess the functional aspect. So the aim and objectives of my study was to study the structural and the functional aspects of meibomian glands in patients of VKC using the lipid view 2 machine and performing the other clinical tests in versus the age-matched controls. So the functional parameters that were calculated in my study were the lipid layer thickness, meibomian gland patency, and meibum quality. The structural components that were assessed were the meibomian gland dropout and the morphological alterations. And we have also assessed the blinking rates in these children. So it was a prospective, observational and a comparative study in which 50 patients of VKC were compared with the 50 age-matched controls. The inclusion criteria were the moderate, persistent and severe grade of VKC. This is the Bonini's classification grading that we have used between the age group of 8 to 20 years. Exclusion criteria, any active or post-infection or use of any immunomodulator, systemic or topical, or use of any medications that are known to affect the meibomian glands. And I want to highlight the part that we have excluded the grade 4 and 5 VKC because they have very large papillae which obscure the meibomian glands in the imaging. And plus the children are quite symptomatic for the examination. So the testing strategy and the examination part. So we started with the slit lamp examination. After that, the dry eye evaluation was done, in which the following tests were done. The tear film breakup time, ocular surface staining, the Oxford grading was done, Shermer's 1 score, and MEIBO scoring, in which the expressibility of the meibomian glands and quality of the meibum that was secreted was assessed. So the MEIBO scoring, it was 0 to 7, and MG expressibility was seen based on how many glands the plugging of how many glands were plugged. So the higher the number of glands were plugged, and the worse was the score. And the meibum quality, if the higher the score, the worse is the quality of the meibum. So next was the meibography was done in these patients. So we use this lipid 2. So it assessed the meibography, that gland imaging using the autofluorescence, and the autofluorescence was done basically the meibum act as the contrast for its own, and lipid layer thickness and partial blink rates were assessed by this machine. So both the structural and the functional components were assessed of the meibomian glands using a single machine. And then basically semi-automatic technique was used. So manually using the ImageJ software, I have marked out the dropped out areas and calculated the MG dropout percentage. So MG dropout percentage was equal to the MG dropout area divided by the total area. So these were my results. I want to just summarize that the tear film breakup was less in cases. Shermer's was comparable, so we had that evaporative dry eye is present associated with ocular surface damage, and there was poor meibum quality, and there was a significant MG loss in cases than in controls, suggesting a structural damage, and there was lipid layer thickness was less in cases, suggesting a functional loss. And we had made some correlations also. So I just want to conclude by saying that the children have a vicious cycle of inflammation due to the disease itself and due to the dry eyes. So they need to be co-managed. VKC patients, the allergy part and the dry eye part need to be co-managed. Thank you.
Yeah, thank you. Judges, Dr. Tanmay, please come on the stage.
In your inclusion criteria, you have included grade 1 to 3. How you have excluded grade 1?
Sir, we have just included.
Your control maybe many cases have grade 1 VKC. VKC?
Sorry, sir. Sir, we have not included grade 1, sir. Sir, just 2B. Sir, just grade 2B were included.
Okay.
Grade 1 were excluded, sir. Due to the severity was less, so we were not expecting any kind of changes in grade 1, so they were excluded, sir.
All the cases were basically compliant for all the dry eye examination or
Sir,
were excluded
sir,
because children are not so compliant.
Exactly, sir. Sir, so honestly, sir, we took around 70 to 75 children. The children who completed all the examination were included in the study, sir. Further, matlab, yes, sir. Sir,
You should have mentioned how many cases you have excluded during examination process. In initial recruitment, then
sure, sir. I take
exclusion.
care.
Yeah.
What's your take-home message?
Sir, that dry eyes is being neglected part in the patients of allergic conjunctivitis or the VKC. Sir, the cause or the basic pathophysiology is still a question mark in these patients, sir. That what is the cause of the dry eye or the evaporative dry eye in these patients? So, the changes in the meibomian glands are suggestive that it is probably the most likely underlying cause for the dry eyes in these children, and it need to be co-managed, sir. Because if it may have some long-term implications on this. If the so, thank you.
Thank you so much. We'll move on to the next speaker, who is Dr. Tanmay. Dr. Hirika is here. Yeah, please be very ready with your presentation. Yeah. So, Dr. Tanmay, you can start your presentation.
A beautiful background reflects a beautiful study, and a background, I mean extensive literature review and discussions with proper guidance and accurate data collection. The study by Dr. Pradeep Venkatesh et al., which reported resolution of CSCR after partial sclerectomy, along with wide literature search and discussions, led to the intriguing hypothesis patients developing CSCR might have a thicker sclera compared to normal population. Thick sclera may disturb the choroidal venous outflow and transscleral venous outflow. We examined this hypothesis in our presentation. Good morning to all. My thesis was to study the relation of anterior scleral thickness and choroidal thickness in patients of central serous chorioretinopathy. All relevant background images are from the study population. The aim was to determine whether anterior scleral thickness varies significantly between cases and controls. Primary objective was to compare anterior scleral thickness in cases versus controls. Secondary objectives were to find agreement of mean anterior scleral thickness measured by AIOS-ARC and UVM
Good
in
morning,
cases,
ma'am. Please
and to find
Good morning.
correlation of anterior scleral thickness with posterior choroidal thickness. The study was designed as prospective case control study and conducted after approval of ethics committee. Study population included patients of CSCR as cases, individuals with refractive error as controls, and one eye per individual only when was selected when they provided informed consent. Excluded individuals with any other ocular comorbidity, refractive error greater than 3, age less than 18, image acquisition, substandard image acquisition, and who did not consent. Age matching achieved by stratification of age groups, gender matching achieved by selection of equal number of controls. Test of significance was t-test and Fisher exact test. Power of study was 90% and p less than 0.05 was considered significant. Scleral thickness was measured 1 mm and 2 mm temporal to temporal scleral spur by AIOS-ARC and UVM in cases and only by AIOS-ARC in controls. By AIOS-ARC, mean thickness among cases was 703, controls was 667, and mean difference was significant. Measurement by UVM was done in a similar manner, and this excluded the conjunctival renin tissue, and controls did not undergo UVM. Mean difference between AIOS-ARC versus UVM was 46, which was significant. In all patients, CT was measured subfoveally and 1 mm nasal and temporal. CT among cases was 443, among controls was 373, which was significant. In cases, we found a weak positive correlation between CT and AST by AIOS-ARC. In controls, the correlation was weaker, but it was not significant in both. A very weak negative non-significant correlation was found between CT and AST UVM in cases. AIOS-ARC and AST UVM showed a positive and statistically significant correlation. Limitations were scleral thickness measurement by OCT included episcleral tissue, whereas UVM did not. Single non-blinded individual did the measurements, which were manual, only measured temporal sclera, and away from possible site of pathogenic mechanism. Lastly, inclusion of all types of CSCR cases. To conclude, anterior scleral thickness varies significantly between patients with CSCR versus normal individuals. Agreement between AST by ASOCT and UBM is poor. AST by ASOCT is positively correlated with posterior choroidal thickness, while AST by UBM is negatively correlated in patients of CSCR, but the correlation is not statistically significant. I take this opportunity to thank my guide, Dr. H.S. Trehan, co-guide Dr. Raji K, all my teachers, colleagues, and especially the patients who agreed to give their name and their time and energy for this. Also, my sincere thanks to AIOS and ARC for giving me the opportunity. Thank you.
Thank you.
In your inclusion criteria, basically, refractive were less than 3 diopter was basically taken. What was the basis for that?
Sir, we took
Please
refractive
close
error
the door outside.
less than 3 because in myopic eyes there is increased thinning of the sclera, and in case of hyperopic eyes or nanophthalmic eyes there is thickening of sclera that rules out our this study this thing.
So another thing was inflammation was ruled out in all the cases, especially intersegmental inflammation. Suppose somebody has episcleritis or maybe you can say inflammation anteriorly.
Yes,
So because it can change the anterior skull thickness.
yes sir, completely agree with you sir, and we particularly taken care of that. We only included refractive error cases less than equal to 3 diopter as controls, and cases of CSCR were without inflammation. CSCR without, there was no inflammation in the eyes, that was clarified.
Was there any subgroup analysis also in acute and chronic cases?
No sir, that was one limitation of our study, because we took all the CSCR cases, whether it is acute or chronic or some resolved cases also. So we took all kind of CSCR cases. We did not separate that way.
What point of time have you taken the measurements in the patients?
Yes sir, that is again because we have included all types of cases, acute and chronic. So there was
No, you are saying you have taken resolved also.
yes sir, because some patients are treated earlier, some patients are acute cases, so that is a
But don't
limitation.
you think there would be a difference between the acute case and the resolved case?
Sir, there is, I researched along reviewed some studies also sir. There is no difference in the choroidal thickness. So we presumed that there might be no difference in scleral thickness as well. But your point is valid sir. That is again one of the limitation of the study.
Thank you.
Thank you so much. We welcome our co-chairperson, ma'am, Dr. Manvi Sindal, ma'am. Please welcome you, ma'am. So, and the next speaker, Dr. Yashovardhan, is he present here? Yeah, please be ready with your presentation.
Macular structural abnormalities in patients with metamorphopsia after rheumatogenic retinal detachment surgery. So metamorphopsia is a very highly
Just
prevalent
1 minute, your
symptoms.
presentation is yet to come. Wait. Please start our presentation, AV team. On that side, go to that podium, please.
Metamorphopsia is a highly prevalent symptom in 2/3 patients postoperatively, and that impairs the fusion and compromises with the binocular single vision. And there's a high risk of binocular diplopia, asthenopia, or retinal detachment. The aim was to determine the macular structural abnormalities in patients with these patients after PPV, and to identify the macular structural changes after successful PPV surgery and with help of OCT and FAF. So the study design was that of prospective, done in Arvind Eye Hospital, Coimbatore, at 18 months for 30 patients, and in patients complaining of metamorphopsia 3 months post-operatively. My inclusion criteria for the study was patients more than 18 years of age, post-RRD repair with vision better than 6/18, visual acuity, patients with no media haziness, patients with successful retinal reattachment, and post-operatively macula off, pre-operatively macula off. Medical history was taken. It was measured with the help of OCT, SD-OCT, and fundus autofluorescence. Diagnosis was made based on laterality, total, subtotal macula of PVR grading, breaks, and lens status. And past vena vitrectomy with tamponade was done by senior experienced surgeons. Post-operatively 3 months, we took the BCBA, contrast sensitivity, Amsler grading, slit lamp examination, OCT and fundus autofluorescence. So results were that of 80% were that of silicone oil, while left eye was 53%. Duration was ranging from 2 days to 90 days. What we saw in fundus autofluorescence was retinal vessel displacement, as you can see with the white arrows, the hypofluorescent lines showing the imprints of the previous vessel position. We saw cystoid macular edema, retinal folds, lamellar macular hole, inner segment, outer segment disruption. So in OCT findings, what we saw the most was inner segment, outer segment disruption, and that of fundus autofluorescence finding, we saw retinal vessel displacement as a maximum patients. On basis of the type of surgery, gas tamponade with retinal vessel imprinting, we saw similar results with gas as well as oil, while others were more with oil. And we found statistically significant difference between groups of gas tamponade and silicone oil tamponade for vitrectomy. So what we found here we can see is that there was a statistically significant association with respect to retinal vessel displacement on fundus autofluorescence with type of the tamponade agent. 4 patients in our study had no macular changes on OCT, and this could be because of glial proliferation on the photoreceptor layer causing traction on the macula, which missed on the imaging modalities. And none of the studies found any duration of RRD as any significant risk factor in our study. And we compared it with the other studies that happened, and we found there were similar results seen in other studies showing that there could be development of metamorphosis due to this. And this study demonstrated that retinal vessels may move downwards post-operatively, and hence could be the main cause for post-operative metamorphism, especially with gas tamponade. And FAF was a very useful imaging modality, while it was not affected by duration of RRD and post-operative BCVA, and long-term FAF studies will be needed to demonstrate this. These are my references. Thank you so much.
Thank you.
In your study, you have assessed how you have assessed metamorphosis only on Amsler grid test or any other objective
No,
test?
only AMSA. We have not done any others test. We have not done it very quantitatively. Only a qualitative measurement was done.
Was there any basically you can say subjective assessment? Some patient can tell metamorphosis, some can overemphasize, and some can basically tell there may not be a metamorphosis.
It's a very relative.
How it was negated.
So mainly we took patients which had vision better than 6/18. So here what we wanted was to see the quality of vision rather than the quantity. And wherever patient was complaining that he's seeing some distortion of line, we were seeing Amslers, and we could see that he could see those, we could see it on the Amslers grid that patient is not seeing a straight line. So that is how we took. We didn't take any other investigation into account.
Different agent were used.
Yeah, we use silicone oil and gas as both.
Was there any association with?
So what we saw was with gas tamponade, we saw there were more retinal vessel displacement seen on autofluorescence. But since our sample was small, we cannot be conclusive. There was no significance found according to statistics. But other studies have shown that gas tamponade shows these significant changes. Silicone oil doesn't show that much. So we were conclusive with the fact that compared to silicone oil, gas tamponade could cause metamorphopsia more. And also other studies supported this finding, but because our sample study was small and our gas tamponade patients were lesser, we could not be conclusive about it.
Metamorphopsia, how did you actually assess? Can you tell me the procedure?
So sir, when we have seen patients 3 months post-operatively, first we saw that visual acuity is better than 6/18, so we have included them. Then again,
No, just metamorphopsia part.
just complaints and Amslers.
Amslers, how many charts?
So we did only the, we didn't do all the charts, the basic one we have done, sir.
Do you know how many charts?
9 charts.
So you have it done only on one chart?
Yes, sir.
Why?
Just we thought that if the patient is, we mainly wanted to see the quality of vision.
No,
so
no, but what's the harm in doing?
Yes, sir.
If you are doing one chart,
Yes, sir.
at
We
least
could.
couple of
Yes,
more
sir.
minutes.
Yes, sir.
Amin is here. Yeah, be ready with your presentation.
Good morning all. Today I'll be talking about the efficacy of adalimumab in the control of pediatric non-infectious uveitis. So some background and rationale. Pediatric non-infectious uveitis is an asymptomatic sight-threatening disease. First line of management for it is corticosteroid along with other immunosuppressants like MMF or methotrexate. methotrexate. However, a significant proportion of these patients remain refractory to treatment, and the pro-inflammatory cytokine, tumor necrosis factor alpha, is thought to play a key role. Adalimumab, a recombinant human immunoglobulin monoclonal antibody that specifically binds to TNF-alpha, is the only systemic biological agent currently approved for treatment of non-infectious uveitis. And despite FDA approval, there is a paucity of data on the ocular outcomes in pediatric non-infectious uveitis. So a bit about pediatric non-infectious uveitis, that it does not present like adult uveitis. There is no pain, redness or photophobia usually seen, and these patients then because of this present in an advanced stage when the parents notice some squinting of the eye or some whitish reflex from the eye, and that is why screening is the key in such patients. Corticosteroid use in pediatric population and otherwise also leads to a lot of complications systemically as well as ocular-wise. And to avoid such side effects of corticosteroids, biologicals like adalimumab are the need of the hour. So the objective of my study was to assess long-term control of pediatric non-infectious uveitis by adalimumab, focusing on the change in best-corrected visual acuity and its steroid-sparing effect. Apart from that, to assess the drug retention rate on the basis of rate of discontinuation due to inefficacy, loss of efficacy, side effects, or ocular remission. The materials and method included study being prospective observational study. Study period was 1.5 years. Our patients were basically refractory pediatric non-infectious uveitis patient on multi-drug regime already and now being started on adalimumab. Sample size was 7 for my study and I have collected data for 10. These were my exclusion criteria. Methodology, visual acuity as well as anterior and posterior segment evaluation of these patients were done, and then these patients were followed up for a duration of 12 months and were monitored every 2 monthly for any flare-up of ocular inflammation, side effects, worsening of ocular morbidity were documented. So terminologies were clearly defined as per Sun classification and other studies on the same topic. For refractive uveitis, active inflammation, inactive inflammation, as well as treatment failure. Coming to the demographics, 70% of the population were females and 30% were males. And anatomical classification-wise, anterior uveitis predominated our study. When we talk about the etiology, as it is commonly seen in pediatric non-infectious uveitis, GIA was the leading cause of uveitis in our study too. When we see this chart, we can see the response of ocular inflammation to adalimumab when compared to baseline to 12 months. Majority of the patients were having no ocular inflammation at the end of 12 months. This is a chart depicting the visual acuity trends over the 1-year duration of the study, and visual acuity was decently well maintained throughout the period. And if we talk about the mean number of steroidal drops per eye per day, there was 73.3% of patients were off steroidal eye drops after 12 months of use of adalimumab, which was again statistically significant even way before at 6 months and as well as 12 months. When we talk about systemic steroid trend over 1 year, oral steroid, 7 out of 8 patients were off systemic steroids too at the end of 1 year, and this was again statistically significant at 6 months as well as 12 months. When we talk about the drug retention rate, none of our patients during the study period reached any treatment failure, and the side effect profile of adalimumab worked in favor of compliance as shown in our study, where 90% of the subjects were compliant to adalimumab. One patient was a drug defaulter because of lack of availability of adalimumab in their place. So the effectiveness of adalimumab was evident as oral steroid-free remission was seen in 87.5% of our patients, and 73% patients were off steroidal eye drops. None of our patients during our study period reached treatment failure. 90% of the subjects were compliant to adalimumab. We compared our study with 2 other studies which were retrospective as well as multi-center studies, and the data was very much comparable. The response to topical steroid eye drop remission was very much comparable. The limitation is limited size of the study, and to conclude, adalimumab is effective in controlling ocular inflammation, delaying treatment failure, and has beneficial steroid-sparing effect in cases of pediatric non-infectious uveitis. Thank you.
This was your thesis topic?
Yes, sir.
How sample size was calculated?
So sample size was calculated by seeing the other studies which have been done on this topic particularly, and then calculated by power
in such rare cases, sample size will be very high. Basically, this is non-probability sample. You can't calculate sample size in such a small sample size. Only 7 was calculated.
Yes, sir. But as per the other studies also, because multi-center studies also had cases of 17. So, and since we were having these patients and there was no other studies done in India per se on this topic, that's why it was important.
A rare phenomena, you are selecting some topic which are only 7 the initial calculated sample size, not basically calculated. This is non-probability sample, and we have got 10 cases. Another thing is, what was the duration of a SWAT when it was labeled as multi-drug resistant?
So, sir, 3 months.
3 months. After 3 months,
Yeah.
it was labeled as
Yeah.
multi-drug.
So these all patients were on methotrexate or MMF along with oral corticosteroid, and topically they were at least on 3 drops per day at 12 weeks. Those were the patients who were selected.
But there is a role, basically topical steroid has a very limited role, especially in
Yes.
cases of posterior
Yes, sir.
uveitis or
Yes, sir.
panuveitis.
Yes, sir.
There is a role of systemic steroid or whatever.
Yes, sir. Systemic steroid was also
biologically,
going on, and we all got a good sparing effect, steroid sparing effect at the end of 6 months itself.
In 20% of cases, you have written Blau syndrome. What was the other manifestation of Blau syndrome?
Sir, loose stools, distended abdomen at time of presentation was one of the things.
Ocular manifestation.
Ocular manifestation was anterior uveitis, as well as apart from that there was vitritis, mild vitritis at the time of presentation.
Any other manifestation you know?
I can't recall as of now, sir.
Have you seen Blau syndrome?
Sir, when I saw it,
How it was basically diagnosed? Basically by rheumatologist or on your part?
sir, these patients were initially presented to a rheumatologist and then referred to our site to check for uveitis as well.
BSK is one of the commonest presentation.
So follow-up was for 12 months. That is again something which, like this study is still continuing on because we have to collect a more sample size.
No,
And
this data in your slide
Yes,
is for follow-up for how many months?
1 year or 12 months.
For all 7 patients?
Yes, all 10 patients.
Okay.
Yeah. Thank you so much.
So, in today's world where cataract surgery is no longer a sight restoring surgery, it's more of a refractive surgery. Calculation of IOL power is one of the most crucial factors for the refractive outcome of cataract surgery. It includes proper selection of IOL material, optimization of IOL constant, informed formula choice, and the use of modern optical biometry. So in my thesis, I have compared 5 standard IOL formulas and 2 artificial intelligence based formulas with each other. From standard IOL formulas, I have taken SRK2, SRKT, Haigis, Hoffer-Q, and Barrett's universal formula. And from artificial intelligence based formulas, I have taken Ladas and Hill RBF formula. Materials and methods. It was a prospective observational study where 100 patients, 100 consecutive patients who underwent cataract surgery from 2020 to 2022 at Government Medical College, Srinagar were taken. Pre-operative optical biometry was performed with optical low coherence reflectometry-based lens star. Based on SRK-T formula, single style monofocal standard lens was implanted in the back. Inclusion criteria were basically 3. First was the patient's age, whose minimum limit was kept as 18 years, and single surgeon cases of monofocal IOLs were put, and clear corneal incisions of 2.75 mm was given. Exclusion criteria were incomplete biometry, patients unable to go PCI biometry, post-operative corrected distance visual acuity less than 20/40, astigmatism greater than 4, intraoperative or post-operative complication, any previous intraocular or refractive surgery, any corneal disease, or any retinal pathologies. As already said, data was collected from 100 cataract size of 100 patients. The mean axial length of patients was 22.97 plus minus 0.09. Patients were grouped into 3 categories based on axial length, less than 22.5, 22.5 to 24, and greater than 24. Highest number of patients were found in normal, whereas least number of patients were found in long axial length. So results were based on mean absolute error, median absolute error, and mean prediction error. And the conclusions were basically mainly derived from mean absolute error. Across all the axial lengths, Barrett's had the lowest mean absolute error, where SRK2 had the highest mean absolute error. Also, Barrett's had the highest number of patients within the prediction error of plus minus 0.25 diopters. In patients with short axial length, Hoffer-Q had the lowest mean absolute error. Again, SRK2 had the highest mean absolute error. And Hoffer-Q had the highest patients, 45, within the prediction error of plus minus 0.25 D. In patients with normal axial length, Barrett's had the lowest mean absolute error, and SRK2 again had the highest mean absolute error. Again, Barrett's had the highest number of patients with prediction error of plus minus 0.2. When it came to patients with long axial length, SRKT had the lowest mean absolute error, and SRK2 again had the highest mean absolute error. Again, SRKT had the highest number of patients within the prediction error of plus minus 0.25 diopters. This is a graph representing the data where we can see Barrett's has the mean absolute error in overall patients and in normal cases, whereas Hoffer-Q has it in short group and SRKT has it in long group. So from this we can derive Although the Barrett's, Hofferke and SRKT had lowest mean absolute errors, the values were not that significant when compared to the artificial intelligence-based formulas. So the accuracy of third and fourth generation formulas can be compared to artificial intelligence-based formulas. And as more and more data is being fed into these artificial intelligence-based formulas, we might see an increased accuracy of these formulas. Thank you.
Your study, you have studied mainly three formula, no? SRKT.
Sir, 7 formulas.
7 formula.
Yes, sir.
What were the basically result?
But mainly the axial length and the biometric data of eyes, it depends on the topography of the patients. And in my state in JNK, the results on biometry and axial lengths are the data is very low. So I suppose that is one of the reasons. But also the sample size was only 100 patients.
One of your exclusion criteria was best corrected visual acuity post-operatively.
Yes, sir.
Less than 6 by 12.
Yes, sir.
So what was the reason you have ruled out fundal pathology or any other pathology?
So some patients have with a high mature cataract, they might be amblyopic or something. So we have ruled out any decrease in vision which cannot be explained post-operatively.
In that, optical biometry was possible or not? Suppose.
No, sir. Optical biometry was not possible in that patient.
So why you have basically you have
So
excluded?
in some patients
but
with
it was taken post-operatively. It would have been pre-operatively. It was taken post-operatively.
yes, sir.
So if your machine is not recording, then how it was included?
So it was not included in patients with high axial length.
But you have written post-operatively, na? You have
Yes, sir.
written post-operatively. You have excluded. So what was the reason? It was included initially, and then it was excluded.
Yes, sir.
Due to less best corrected visual acuity. So how it was included? If machine was not able to record.
So it was not included. Only the
No,
patients.
then he's asked. You said mature cataract was the reason why the vision is less than 6. So that is excluded in the inclusion criteria.
Yes, sir.
Now, why did you exclude
Post-operative.
patients with less than 612? That is the question.
So, patients with longer axial length or patients having amblyopia.
No, that is different thing, na? Basically, you are writing post-operatively. You have excluded.
That
How?
would be all pre-operative.
Yeah.
Yes, sir.
Why would that would be post-operative?
Yes, sir.
What is the
Good morning, everyone. The topic of my thesis is randomized controlled trial for comparing conventional versus wide-angle non-contact viewing system for scleral buckling surgery.
हाँ ठीक है ये भी देने का
The principle of scleral buckling surgery is the indentation of sclera and choroid by providing an external tamponade that brings the retinal ray closer to the retinal pigment epithelium and displaces the subretinal fluid away from the tear. Traditionally, the illumination and viewing has been done using an indirect ophthalmoscope with a plus 20 or plus 30 diopter condensing lens. Here we are comparing this with an endo-illumination via chandelier inserted through pars plana in combination with wide-angle viewing system.
हाँ मालूम
So
है
the aim is to
लेकिन हमको
evaluate the
मालूम
results
तो
of
है
treatment with the
retinal-
traditional scleral buckling compared to chandelier with wide-angle viewing system. The limitations of existing literature is that the studies have been retrospective with smaller size. There has been a lack of comparison group and they've not been done in Indian population. My study was a randomized single-blind controlled trial, and the patients with rheumatogenic retinal detachment with PVR less than grade C were included. Intervention group was group A with chandelier, illuminator, and wide-angle viewing system, and comparison group was traditional scleral buckling with indirect ophthalmoscope. The primary outcome measured was anatomical reattachment of retina, and secondary outcomes were improvement in best-corrected visual acuity and per and post-operative complications. We used a Consort 2010 flow diagram for transparent reporting of trials. 58 patients were included, out of which 12 were excluded, and then 46 were randomized into two groups of 23 each. The patients with deep set eyes and post-glaucoma or glaucoma drainage implant patients were excluded. The primary outcome was reattachment of retina, and it was evaluated on day 1, day 7, day 30, and day 90. And it did not differ between the two groups. Similarly, the best corrected visual acuity was also similar between the two groups. The secondary outcome was per-op and post-op complications. In per-op complications, in both the groups, most of the patients did not have any complications per-op, and subretinal bleed was seen in 2 patients. Additional complications that we saw with chandelier was there was a need to shift the chandelier in 2 patients because of poor visualization of break. Lens touch happened in 1 patient, leading to a rosette cataract. In post-op complications, in both the groups, they were similar. 1 patient each had media haze and subretinal residual fluid. Coming on to discussion, in 1980s, Bonnet M used an operating microscope with slit lamp illumination to view the fundus with a Goldman 3-mirror lens placed over the cornea. Later, in 2004, a surgical microscope with mounted slit lamp illumination was used, and later Naruki et al. Used a office system that is optic fiber-free intravitreal surgical system. AIOS et al. Performed scleral buckling with a non-contact wide-angle viewing where the source of illumination was a torpedo light. In my thesis, I observed that the advantages of chandelier and wide-angle viewing system was a wide field of view with adjustable magnification, comparable rates of attachment. Additionally, it acted as a teaching tool with better ergonomics. But the disadvantages were that an intraocular entry had to be made for the chandelier, and there was poor view in hazy media, increased operating time in our thesis because of the lack of experience with chandelier, and the need to change position in 2 patients. Limitation of my study was that it is a small sample size with a relatively shorter follow-up period, and there is a learning curve owing to increased operating time and per-op complications. My conclusion is that the chandelier illumination with scleral buckling using a wide-angle non-contact viewing system, it yields comparable results in management of rheumatogenic retinal detachment and is non-inferior when compared to traditional scleral buckling using an indite ophthalmoscope. These are my references. Thank you.
You have include PVR grade C.
Yes, sir.
Okay. So, was there any difference in grade 1, grade 2, and grade 3 in your finding in the use of chandelier illumination system?
So we only included grade A and grade B PVR, sir. And so no difference was seen with either chandelier or with indite ophthalmoscope, sir.
Okay. So fourth port was made for chandelier or
So there were 3 ports, and we instead of the light source, we use a chandelier using a 25 gauge. Why 3 ports?
Any complication related to that?
Yes, sir. So in 1 patient there was a lens touch and that led to a rosette cataract, and in 1 patient that there was vitreous incarceration at the port site. And in 2 patients we had to change the position of the chandelier because at the position that we had placed we were not able to visualize the breaks correctly.
So, as per your study, whether this is recommended to use or only same light source should be used?
Sir, because scleral buckling has a lot.
To chandelier usage or due to the inexperience of the surgeon?
No, sir, inexperience of the surgeon. So lens touch should not ideally.
That is a confounding factor in your study.
Yes, sir.
Thank you.
I agree. Thank you so much, everyone, for a very nice chairperson and co-chairperson, Dr. Tariq, sir. Dr. Manvi, ma'am.
You would also have one.
Yeah, thank you.
You deserve the best.
Thank you so much. Also, each one of you also will be getting a certificate. Dr. Nishi Prasad from the earlier session, please come. Dr. Tariq, sir, will you please? Yeah. Dr. Sumita Mohapatra. Dr. Sanjay Kumar Thakur. Yes, sir. Sir, please. Thank you. Yeah, Deepak, photo lena, please. Dr. Amit Raj.
You have official photographer?
No, apparently not. Thank you. Dr. Amit Raj, sir. Yeah. Sir, please. Dr. Divakar is not here. No? Dr. Preet Kumar Sodhi, sir. Dr. Jaydev Nanda. Dr. Tanmay Mohapatra. Please come quickly. Yeah. Sir. Dr. Tanmay. Dr. Rohit is not here, right? Yeah. Come. Dr. Tanmay. Dr. Prashant. Dr. Hirika. Ma'am. Dr. Yashovardhan. Hirika. Yeah. Dr. Mazila.
Yashwardhan.
Dr. Ruchi.
Well done. Both no problem.
Thank you, everyone.
Photo?
Yeah.